Thank you, Ritesh, from a vitreoretinal surgeon. Now I designate myself as an anterior segment reconstruction surgeon. It's a new upcoming branch, and I should ask other fellows and younger colleagues to join this branch, that is anterior segment reconstruction. In the era of super specialty, many a times we are unaware what is happening in other specialties. We also forget to peep into other specialties about new instruments, machine, how they can help in your specialty. 23 gauge and 25 gauge micro scissors and forceps were first introduced in vitreoretinal surgeries. These instruments have found a way in various anterior segment surgeries also, like pupilloplasty, DSEC, and glued IOL. Uh, I'll be talking in this talk, I'll be talking about pupilloplasty. Pupilloplasty is a surgical procedure to alter the shape or function of the pupil to prevent a glare. Now, this is one of the patient has traumatic subluxated cataract with mid-dilated pupil with sphincter tear. So, anterior segment surgeon did an MICS with ECR with IUL, and you can see this is a mid-dilated pupil. There is a slightly decentered lens, or because of the dilatation, the lens is not centered. Because the edge of the lens is coming into the pupillary axis, the diffraction from the edge of the lens cause disturbing halos, and patient says, whenever I drive, my life is a hell. Night time I can't drive. My life ends at 6 o'clock. All this kind of excuses, and every day he used to come into the OPD and sit and describe his agony about his life. So we thought, yes, we should go ahead and decrease his agony. So we planned for a pupilloplasty. What we did here first, we made a paracentesis, and after that, the pilocarpine was injected. You can see the pupil is constricting, and this helps us to take where the sutures can be taken. This is a straight needle on 10-0 Merceline. We call it an STT6. We call this is an as an STT6 needle. The iris is engaged. The other end of the iris is also engaged in the suture. Then the needle is docked into an 23 gauge curved cannula and is brought out through the paracentesis. You can see the engaged iris tissue here. Once the suture is brought out, the distal, this is what we call as a distal end, this is the proximal end. The distal end of the suture is pulled out, and now what you have is three sutures here. This is one suture, two suture, and three suture. So you have to take four throws or three throws in this suture, and this will be the tying knot. And this knot, we call it as a Siepsel's knot. This is a sliding knot where the knot is put outside the eye, and once we pull the proximal and the distal end, you can see the sliding knot inside, and its tightening of the pupil is done. The second throw is taken, and similarly the suture is cut, and this is the end result. You can see it now, the pupillary, at the pupillary edge you cannot see the edge of the IOL, and post-operatively this patient was happy. This is another patient. This was Dr. Lalit's patient, had undergone trauma and came with retinal detachment with subluxated lens. So a lensectomy, vitrectomy was done with silicone oil injection, and you can see an inferior SI in a emulsified oil in the anterior segment. So we planned for an glued sterile fixated IOL with removal of oil plus pupilloplasty. So once the what you do, you coat the endothelium with chondroitin sulfate, and just press the posterior lip. The infusion is there. The oil comes out through this tunnel. Then the three-piece IOL is injected into the eye. The important thing here is catch the tip and only externalize once the whole lens is delivered. The second haptic is also externalized, and these haptics are internalized into chariot tunnel, which is made by 26 gauge needle. Once this is done, 10-0 suture is taken on STC6 needle. The iris is engaged, and then this needle is docked into a 23 gauge cannula and is brought out through the paracentesis. What we'll be practicing is in fourth row pupilloplasty. What you do, you have three sutures like I showed you in the last video. You give four throws. You need not to give 3, 2, 1. So once the fourth row is given, the knight slides in, the knot slides in, and you can see we have constructed the pupil. The sutures are cut with the help of vanas, and glue is placed over the flaps. And this is the post-operative picture. This patient improved with 6/9 vision. Uh, this is another patient. We did a glued IOL in this patient. Because of the trauma, you can see the pupils are not constricting. This is without any mydriasis. And important thing here is don't put adrenaline into the vitreous fluid or the cannula. The pupil size is checked. You make paracentesis, one at 5 o'clock, one at 10 o'clock, and another at 2 o'clock. So edges of the pupil are taken and it's docked into the needle. This needle is brought out through this paracentesis, and the other end of the needle is again taken, and we take small bites of the pupillary margins and bring it out from this paracentesis. And the third thing, we do it again from nasal to the temporal side. Once 360-degree suturing is done, what we do is we tighten this, and you can see this is how the pupil appears after surgery. So this is the post-operative picture. From 6 millimeter pupil, we were able to reduce it to 3 millimeters. So to sum up, micro scissors and forceps has become an important aid in construction of anterior segment surgery, enhancing our results and making our life easier. Thank you very much for your kind attention.